This presentation number 8 in the GIT series concerned with duodenum, prepared by Prof. Sharaf and revised by Prof. Hani Sami. If we have multiple duodenal filling defects, we can give a diagnosis of either hypertrophied Brunner's glands or polyps, or the most important is lymphoma. This is the appearance. Multiple polypoid filling defects. If we have thickened duodenal mucosa, we can check for renal disease, check for pancreatitis, because kidney and pancreas can result in thickened duodenal mucosal folds. Of course, we should exclude lymphoma and duodenitis. Varicose varices are rare to involve the duodenum, but it can be there. Of course, Zollinger-Ellison syndrome is another possibility. This is the appearance of the thickened mucosal folds of the duodenum. Again, we should put the famous diagnosis of lymphoma on the top, then consider whether there is chronic renal disease or pancreatitis or something like that, but lymphoma should be excluded. If we have a fistula, it can be post-operative due to sphincterotomy, or presence of cholecystitis, gallbladder carcinoma, or duodenal carcinoma. So carcinoma of the gallbladder, carcinoma of the duodenum, both can do fistulation, and post-operative can be, and cholecystitis is rare to be. Here is the biliary tract, and this is the common bile duct, and the region of the gallbladder is not well opacified. Then the distal end of the common bile duct is directly going to fill that part of the duodenum. Sphincterotomy, to be continuous with that part of the duodenum which is markedly full. Sphincterotomy can result in such appearance as reflux can go up. Duodenal obstruction when we have congenital hypertrophic stenosis in children, annular pancreatitis, which is a congenital anomaly, midgut volvulus. Of course, when you should exclude carcinoma of the duodenum, and we have the famous superior mesenteric artery syndrome, and if there is intramural hematoma. So what is this is the cap, this is the pylorus canal and cap, second inch of first part, second part, third part markedly dilated and stopping here, with traces are only seen passing. This is a typical appearance of superior mesenteric artery syndrome. Widening of the lobe, of course, we should exclude lymphoma, aneurysm, pancreatic disease, gallbladder from above, or gallbladder cyst. This is the appearance of wide C-shaped loop, with or another term is called ironing of the pylorus. Ironing of the pylorus, the same as ironing of the pyloric antrum. Pancreas, pancreatic masses, lymph nodes, retroperitoneal or aortic aneurysm, and if the impetition is from above, it is due to maybe gallbladder. Different appearance of duodenum. Sometimes post-operative we can get obstruction of the afferent loops, and here is the appearance of the U-shaped loop when cut transversely by CT. It appears like that. And this is a stomach with gastrojejunostomy and a large ulcer seen at the stoma. It's called stomal ulcer. This is called stomal ulcer. This is gastric, and this is duodenum, and this is stomal ulcer. Here we have definite narrowing of the duodenum with dilatation of the stomach above. It's a chronic structure. Cancer papilla can result in curvaceous, according to curvaceous, into dilated, markedly dilated urinary bladder. This is the mass itself. And here's the common bile duct and the gallbladder full of stones. And this is the carcinoma, stopping here with a stent between the duodenal loop and the distal end of the common bile duct as an attempt to overcome the obstruction in cancer papilla. This is the papilla, pregnant one, large one, ovoid one. It is an adenoma at the papilla. Here it is again as seen as filling defect along the papilla. Of course, this is the appearance with the apple core appearance of carcinoma anywhere affecting a tubular structure. The tubular structure is showing shouldering here and there, here and there, and this is the mass surrounding, and this is the narrowed short segment which is delineated with bearing. Here in the duodenal carcinoma, I think it is evident that if this is the esophagus, fundus, body, pylorus, mucosa is good, cap, loop, mucosa appear good, but fourth part of the duodenum start to show irregularity and definite abnormal outline due to carcinoma changes. If this is the stomach transversely seen across the abdomen and this is the duodenum, then it is tapering, narrowing. There is tapering, narrowing, and there is large soft tissue shadow appearing here due to enlarged lymph nodes compressing on the duodenum and converting it into very narrow tube, and this is lymphoma. Lymphoma can encase loops, can encase vessels, can encase the distal duodenum as here. Large masses which is seen as negative shadows are seen with duodenal lipoma. The pancreas is here. If the pancreas invades this duodenum and the duodenum is showing a very narrow segment here, this area, and then the cap is good, the pylorus is good, the fundus is good. So we have here something wrong, and this something wrong is due to pancreatic invasion of the duodenum. Subserosal deposits of the duodenum can again impress on the duodenal mucosa, causing narrowing, but here there is multiple segments of narrowing are seen here and there, denoting subserosal deposits. Usually such an appearance coming from down or coming from bronchogenic carcinoma. Don't forget bronchogenic carcinoma as a cause of any abdominal metastasis. In metastatic melanoma, remember the target sign. This is the target sign, a halo zone with barium fleck. It's an ulcerating segment, halo zone with barium inside, and these are the appearances of metastatic melanoma. Now coming to this case, 44 year woman with trauma following motor vehicle accident, and an axial CT scan with only oral contrast, no intravenous, shows a hyperdense mass in the lateral wall of the second part of the duodenum. This is the part, this is the region, this is the region. An axial contrast enhanced shows that the mass is not enhancing in the lateral wall of the second portion of the duodenum. The mass is not enhancing in this area. Fluid related to hemorrhage is present in the retroperitoneum anterior to the aorta. So anterior to the aorta, inferior vena cava, paracolic. So if you look here, this is triangular opacity which extends this way. This triangular opacity denotes peritoneal, intraperitoneal collection. The same is here, intraperitoneal collection. So we have mass-like effect and the mass is not enhancing, and there is intraperitoneal fluid, and as well as retroperitoneal fluid here and there. If we go down, there is the non-enhancing mass in the duodenum, the non-enhancing mass in the duodenum, and this was the case of duodenal submucosal hematoma. Submucosal hematoma. Of course, once there is contrast here and there, that means there is no complete obstruction, but the hematoma is extending along the lateral aspect of the duodenum and is not giving contrast, and we have intraperitoneal fluid, retroperitoneal fluid, peritoneal fluid here also. That means multiple injuries occur, and this is the result. Duodenal hematoma with multiple fluid collection, small collections scattered within the peritoneum. Here is the hematoma again, and here is the hematoma in the axil, and the presence of contrast does not indicates that there is no obstruction. The differential diagnosis of duodenal hematoma could be duodenitis, could be adenoma, could be lymphoma, could be mass lesion. Duodenal hematoma occurs typically in children or young adults as a result of blunt abdominal trauma. The mechanism in this setting involves crushing of the duodenum, usually with a fixed retroperitoneal second and third parts. It also can occur in the setting of anticoagulation, bleeding disorders, and something whether with or without biopsy. Upper gastrointestinal will show abrupt cut-off varium in the duodenum of the stomach if there is complete obstruction, but usually the obstruction is not complete. Typically, the changes are occurring along the lateral aspect of the duodenum in the second part. The high density is best appreciated on unenhanced scans. Ultrasound may show hyperechoic duodenal mass, which becomes heterogeneous and more hyperechoic with time. MRI shows T1, T2 hyperintense, non-enhancing material within the duodenal wall consistent with hemorrhage. Thank you.